Hi friends, good evening. I'm Dr. Ashutosh Gupta and today we're going to talk about intrauterine growth restriction. Okay, so commonly used as a IUGR, right? So for all practical purposes, we always believe that IUGR is a uteroplacental insufficiency. So meaning thereby that once the baby is there in the uterus and therefore there is some mismatch between the demand and supply, meaning thereby as the baby is growing, the uterus is not able to supply the good amount of nutrition both from the uterine arteries and the umbilical arteries, and therefore we do have this sort of an growth restriction to the baby, right? But similarly, on these lines, today we're going to talk about the maternal conditions leading to IUGR. So the clinical picture might look like as a pre-IH and pre-eclampsia. Let me come back to it again. दिखने में ऐसा दिख सकता है कि हमको यूट्रोप्लेसेंटल इंसफिशिएंसी और पीआईएच की जैसी क्लिनिकल पिक्चर को देख रहे हैं और काफ़ी सीवियर आईयूजीआर हमको मिल रहा है. But when we looked around and we probably dig down and we did some investigations to the mother, and we identified that there was some chronic maternal conditions that was leading to this severe IUGR, and which gave this clinical picture of an PIH and preeclampsia. तो पहले ये दो केसेस इनसे समझते हैं, फिर ये देखते हैं कि इसको किस तरह से हम मैनेज करते हैं. दिस इज द केस वन. इसको ध्यान से देखिए. तो हम 32 वीक्स पे इसको देख रहे हैं एंड देन द बेबी इज सॉर्ट ऑफ एन वेरी सीवियर आईयूजीआर. तो इसको ध्यान से देखें. सो ये वेट है बेबी का, और एक डॉट ऐसा है कि दैट दिस लेडी हैड कम टू अस एट 20 वीक्स. ओके, तो जो पहला डॉट है वो 50th सेंटाइल पे है. जो दूसरा जो डॉट आ रहा है वो -2 SG से भी नीचे है. So, and it is true with everything, like for the biometry and for the ACFL, right? So then we are just trying to look around कि what are the possible regions for it, right? And then we see कि थोड़ा सा uterine arteries की जो pressure है वो ज़्यादा है, resistance जो है वो ज़्यादा है. But इतने severe IUGR में we could have expected it to be an absent endostolic flow. तो umbilical artery flows normal है, right? And so this is the umbilical artery RI and PIA, which is high but well within the normal range, and this is the amniotic fluid leading to oligohydramnios, right? And now we see the second case. So this is also the similar lines as a matter of fact, and we are seeing her for the first time. So all the parameters they are at -2 SD, meaning they're at fifth centile, and then the AC is slightly lagging behind, right? So this is the abdominal circumference. तो ये थोड़ा सा lag कर रहा है, and rest about all the biometry is at -2 SD or fifth centile. And yeah, definitely the uterine arteries are abnormal, but dominant right uterine artery वो उसकी flows normal है. So right RIPI is normal. Similarly, the umbilical artery flows are also in the normal range. So this with this severe IUGR, we could have expected it to be an absent endostolic flow, तो वो नहीं मिल रहा है हमको, right? And then we are identifying the oligohydramnios, right? By these two cases, what we want to understand and is this that with this severe IUGR, we could have expected the umbilical artery flows to be absent. So meaning thereby absent endostolic flow would have been there, and then probably it have classified into an classical uteroplacental insufficiency. तो जो अल्ट्रासाउंड है वो एक मैथमेटिकल एक पजल होती है दैट प्रोबब्ली वी नीड टू सॉल्व. सो मीनिंग देयर बाय दैट instead of getting into this uteroplacental types and PIH and preeclampsia, there could be some maternal conditions, meaning thereby that chronically there could be some medical problems happening into the mother and superimpose the pregnancy, and therefore it gets dwindled down and then starts to fail. So in the first case, this was a celiac disease, and then we have had the pregnancy now, and therefore in celiac disease is also an autoimmune conditions, and therefore it is an inflammatory condition which might present as an sort of an abnormal urinary flows, and a lot of other conditions is also there. So there is an inflammation going on in the placenta also, into the gastrointestinal tract of the mother also, and therefore getting reflected onto this very severe IUGR to the baby, right? And then the second case was a protein losing nephropathy to the mother. So we just looked around and then asked those pertinent questions and did some investigations so as to identify that she's losing a lot of proteins. It was not a classical nephrotic syndrome, and but she was the urine protein was 2 plus, and she was having this the high blood pressures. but then it is not a classical sort of an uteroplacental insufficiency. So meaning thereby that whenever we are suspecting this IUGR, and the uterine arteries can be abnormal. So abnormal can be there because of the chronic medical conditions that is happening to the mother also. So mother can have some inflammatory bowel disease, mother can have some IgA enteropathy, mother can have some protein losing nephropathies, or a systemic illness, or autoimmune conditions. And in that case, like in a celiac disease or an inflammatory bowel disease, in those cases, if there is a pregnancy, so that can also land up with a very severe IUGR. But the clinical management is absolutely different between all these three cases. So classical IUGR or a uteroplacental insufficiency would need low molecular heparin and ecosprin, which would not work in a cases of a celiac disease. Similarly, we would need a nephrologist opinion if the mother is having a protein losing nephropathy, and sort of an and then she is losing the protein, or she is not absorbing the protein by using an inflammatory bowel disease. So the management changes accordingly depending upon the etiology which is leading to the severe IUGR. So severe IUGR is the basic point, and the basic premise is this, that the mother's condition chronically, the mother could have some medical conditions leading to this severe IUGR. So in these two cases, we would have expected an absent endospheric flow in the umbilical artery, which was not there, right? So that is how it is. Thank you very much for your patience.